Hey, good afternoon, everyone. Thank you for joining this is kind of AI Methods for Health Data Science Seminar Series. This is organized by the ASA StatsUp AI Interest Group. The group aims to organize activities that empower institutions to participate more actively in AI research and leadership. This is the website of the group, and then we will also upload seminar recordings to this YouTube channel. Today, it is my great pleasure to introduce today's speaker, Dr. Jiang Bian. Dr. Bian is a nationally recognized leader in biomedical informatics, health data science, and artificial intelligence. Dr. Bian is a author and a Regenstrief Endowed Chair in Cancer Informatics and a professor and a vice chair for translational informatics of the Department of Biostatistics and Health Data Science at Indiana University School of Medicine. He serves as chief data scientist at the Regenstrief Institute, Chief Data Scientist at IU Health, Associate Dean of Data Science of Indiana University School of Medicine, Chief Research Information Officer at IU, Melvin and Brent Simon Comprehensive Cancer Center, and a Regenstrief Institute Deputy Director of Indiana Clinical and Translational Sciences Institute. His expertise spans real-world data infrastructure, AI and machine learning, causal AI, natural language processing, data harmonization, ontology development, and multimodal clinical and biomedical data analysis. Today, Dr. Bian will share his insights on how to translate real-world data into real-world evidence using AI tools. Welcome, Dr. Bian. And then before I'm handing it to today's speaker, just some logistics. So please save your question to the end of the presentation, and then or either type in the Q&A. And then also at the end, we should have some time for questions, and then I will ask you to raise your hand and then unmute yourself. And then Dr. Bian, please take it over.
Thanks, Yi. I think the first thing, well, thanks, Yi, and thanks, Pam, for the invitation. I guess I need to start with some sort of clarification. It sounded like I have a lot of different titles, which I do, but I have to clear the air every single time when I talk. So it's not 8 different jobs, it's just one job. Majority of my things are focusing on how to make data ecosystem work across health system, for operation, for research, for patient care. So to me, they are not in different jobs, it's just one job. And second, I'm not a methodologist. My training is in computer science, so a lot of the things I will talk about are kind of operation, applying methods. And my research is actually actually benefited from statistic rigor and learn from statisticians as collaborators in the past. What I'm gonna share is sort of related to what real-world data is, but also the limitations when you're using real-world data to generate real evidence, putting preferences with some AI, since this is an AI talk. So I'm gonna talk about AI to some degree, but I think the core message at the end, I hope everyone can bring that back, is understanding the data and data limitations, answering the right clinical and research questions, rigorous study designs rather than chasing shiny AI methods. This is just disclosure. I'm not a methodologist. I'm more of an applying data science AI researcher. So my research has been on a lot of different disease domains, and as you can see, a lot of my study have been funded by NCI in the past, but more recently it's been with National Institute of Aging, a lot of neurodegenerative diseases, but also work on diabetes, cardiovascular diseases as well. The majority of our group's research has been on leveraging real-world data to generate real-world evidence in the last probably 10, 15 years. with a range of different methods and tools. I don't think I need to do a lot of introduction to this anymore, but these are the data that's generated through routine care. Everyone here probably is well aware these data sources included electronic health records, administrative claims and billing data, some of the disease registries, and they really complement randomized clinical trial as the gold standard. But what's different is they reflect patient care through that happens in real world clinics. So a lot of real world situations like off-label use, non-adherence, which you don't see that in randomized clinical trial would happen, right? So everyone probably is well aware of the literature about generalizability issues on clinical trials. When they test it in trial, they are perfect, but when it gets into real world, it's different. A lot of the issues are because the environment, the population are different, the practice are different, right? So this is where real world evidence is really important. And everyone probably well aware FDA in the US has been increasingly using real world evidence for their regulatory decision making. It's the same case in Europe with EMA. To some degree, they may be more mature. They actually have more direct guidelines and standards about real world data and real world evidence programs. FDA probably is still trying to catch up. I always like to start with sort of this one because one, this is one of my first few hour ones, but also the clinical question is really interesting to me when I got into this field. So this is actually looking at benefits and harm of lung cancer screening in Florida. I moved from Florida to Indiana last year, so my kind of most of the track record is in Florida. I don't know how familiar you all are about the lung cancer screening guidelines, but it basically is based on the age and smoking histories. Obviously, there's some caveats on specific symptoms and other things, but generally, it's all about age group and smoking history. The old guideline talks about, I think, 55 to 78, 30 pack a year, which means you have to smoke 1 pack a day for 30 years. And the new guideline in 2022, I think, changed it to broader the scope to 50 and 80 and reduced the pack year to 20 pack years. And if you meet the criteria, you should do low dose CT lung cancer screening. Low dose CT is effective, but it have pretty high false positive rates. In the original national lung screening trial, which is the pivotal trial that get LDCT into the guideline, the false positive rate is about 20%. And in some of our real world data studies, it's as high as 40%. I think I remember a VA study, I don't remember the exact numbers, but the false positive rate is even larger than 50%. Now, if you have false positive, the next step is to do invasive diagnostic procedures, which leads to post-procedure complications. And we also found that real-world post-procedure complication rates are much higher than in the original trial. So in the original trial, the complication rate is only about 9%. In our one Florida, which is a clinical research consortium, primarily in Florida. I used to serve as the chief data scientist as well. It covers 16 different healthcare organizations, 10 of them in Florida, 6 out of them are out of the state, about 26 million patients. But anyway, in our one Florida real world data, the post-procedure complication rate is about 16, almost 17%, and obviously it's false positive. It leads to downstream consequences. So it's not just the benefits, we also have to look at the harm. But the evidence is actually quite clear. For high-risk populations, you should do lung cancer screening despite the false positive rate. For low risk, you probably should not. So the grant, what the grant aim to is to generate real evidence on the trade-off of benefits and harm of low-dose CT to help physician and patient make informed decisions. But how do you actually go about studying that with real-world data? The first problem is actually how to determine eligibility based on electronic health records. Right. As I already said, it's mostly about age and smoking history. Age is easy. It's a discrete field you can find. But smoking history in EHR are pretty poor. Even before 2018, there's actually no requirement or standard to capture granular PACA information in the electronic health record system. The 2018 meaningful use requirement actually required the EHR vendors to implement these fields. So you have to capture the smoking history information, but the adoption is actually pretty poor. So for example, in Florida, I came from University of Florida Health System. We actually don't have them in discrete format until late 2020, after COVID, definitely, right? But as clinician, when they talk to patients, especially when they do evaluation of lung cancer screening procedures, they for sure will document this information. But they only exist in physician notes. So this actually led us to kind of derail our initial grant. We thought it's going to be easy. We can just get the data and do the analysis. No, that's not the case. We actually spent the first few years actually developing natural language processing tools to extract this information. And as you can see, the performance of our initial tool is actually pretty high. The precision is over 96%, the F1 is pretty high. And this is actually a very simple rule-based algorithm. And if you have a computer science background, I mean, this is actually very simple regular expressions, looking at patterns and extract the information. But this pipeline actually enabled us to do a few utilization and surveillance studies as well. What you see on the right on the figure is actually the comparison of the smoking prevalence extracted out of the Warm Florida EHR versus the low-dose CT uptake, which you see a big differences. This is actually not possible using structured EHR data alone. And build on this work, we've started to do a lot of more natural language processing studies. And this is another focus that we've been having on social determinants of health. I know this is going to get posted on YouTube, so I'm not going to talk too much about my opinion by SDOH, but it's an important aspect that we should focus on. So this is a PCORI Masters grant where we develop NLP pipelines to extract social and behavior determinants of health from clinical notes in EHR. The cohort that we focused on are primary lung cancer patient cohorts. And as you can see from the right, documentation of SDOH in lung cancer patients are actually pretty high. And if you read through like alcohol use and drug use, it's pretty prevalent. But when you get into some of the other social determinants like transportation, financial constraint, it's less talked about. So there's also documentation issue. And this gets into the some of the caveats on documentation that's uneven, right? So NLP can help us to recover variables from nodes, but both coverage and accuracy are uneven across different groups. You already saw the in the lung cancer cohort, financial constraints and physical activity are less documented, and alcohol use and nutrition is more well documented. And on the right, you actually see a difference in terms of model performance across different social demographic groups. You do see more in white, and but if you're looking at other race, it's less accurate. And then there's a difference between gender as well. So this is actually telling us a few things. One, when you don't see a variable in electronic health record, it doesn't mean the variable doesn't, it doesn't mean the risk doesn't exist. it's just the absence of a record. We really have to think about how do we actually mitigate that, whether it's imputation, whether it's appropriate or not, that's a consideration, or how do we model it, how do we adjust for it. This is actually gets to your expertise on statistic methods of how to accommodate these missing data. But then it get on to a lot of large language model work after COVID. Along the line of NLP, we've collaborated with NVIDIA in 2020, 2021. Florida, fortunately, had one of the NVIDIA co-founder, Chris Makowski, who was a Florida UF School of Engineer alumna, and he's one of the three NVIDIA co-founder. So he donated $50 million to Florida to give us the first few A100 cluster. We had access to over 1,000 A100 at the time. This is early 2020, so that's actually the first generation of the DGX. Now it's a B300. I think now a single B300 probably is equivalent to a few hundreds of A100. But at the time, it's already abundant computing power, so we were thinking, what should we do? At the time, I already became the chief data scientist for UF Health. So one thing that we have access to is all the clinical notes from UF Health patients. So so that's kind of and then large language model research just started. And BERT is the predominant model. That's actually not a true generative LLM model, GPT model yet. But the first thing we did is the Gatatron BERT model, which we trained it on all UFL's patient notes, about 82 billion words, 9 billion parameter at the time. It's trained on 1,000 GPUs. And then as a follow-up work in 2022, I think ChatGPT has not started yet. We've already started working on the GPT-3 model. NVIDIA had a license agreement with OpenAI at the time, so we had access to GPT-3. We did the same thing now with GPT architecture, trained the 5 billion parameter and 20 billion parameter GPT-3 model. And this is only 3 years ago. Now these models are absolutely outdated. And one lesson that we learned is the cost of training these models. For the Gatatron model, it's actually trained on more than 1,000 GPU altogether, and it took us about 10, 14 days runtime. And we did some calculation. It actually costed us probably about $600,000. But nowadays, we're not using it. The newer models, the general domain models, are already surpassing these old generation of models. So were it worth spending $600,000 to pre-train a model? It's questionable. And that actually led us to do a few of the follow-up work. This is what we call MiLlama model. This is when Llama 2 just came out and Llama 3 has not started yet on the open source architecture. The model was pre-trained from scratch using 129 billion tokens of medical data. And it's much smaller than the UF clinical notes corpus. So we only spent about 100,000 GPU hours. And what's different is we actually did instruction tuning using high quality medical QA pairs, and which only cost us 1,000 GPU hours. And we then obviously evaluated on a wide range of different tasks. And at the time, outperform all the other open source medical large language models. And then what's also interesting is we benchmarked MiLlama, which is an open source model, against some of the closed source models. ChatGPT already out at the time. I think GPT-4 just came out. So we benchmarked it against both ChatGPT, which is GPT 3.5 and GPT-4. The first thing we did is looking at zero-shot learning, and our Milama's performance is comparable with ChatGPT, but had a lower performance than GPT-4. But when we actually did instruction tuning on these specific tasks, the Milama actually outperformed GPT-4 on 5 out of the 8 benchmark data sets, which actually show values of open source models, especially with instruction tuning. The field currently is having a consensus is instruction tuning, more reinforcement learning on smaller, high-quality data set may be more meaningful than doing large-scale pre-training in terms of downstream task needs. So we are basically letting these big companies to spend their dollars on pre-training, and then we look at ways to adapt these models. So we've been looking at clinical notes for quite a few years, and then this is right before I left Florida. We actually moved from lung cancer screening using clinical notes. We're looking into imaging surveillance. The imaging surveillance literature is the current guidelines for post-treatment imaging surveillance for lung cancer is actually pretty low quality. ASCO actually rated 6 out of the 7 guidance as low quality. And again, there's a huge disparity. There's actually no comprehensive US data describing the surveillance practice or real-world effectiveness of imaging surveillance. So this R1 was set to quantify who are receiving CT surveillance and why, and comparing the effectiveness of semi-annual versus annual surveillance strategies. We also set to build microsimulation models to produce long-term outcomes and some of the cost-effectiveness evaluation of different surveillance strategies. So I left UF, I left MPI to a colleague at UF, but I'm still fairly actively involved. We're actually looking at renewing one of the early lung cancer screening grant based on some of the newer imaging surveillance works that we've been doing right now. But that thread also led us to think about modalities beyond structured EHR and clinical notes, moving towards multimodal foundation models. So in this one, we are actually looking at vision language model for low-dose CT report generation. I don't know how many of you are actually familiar with radiology workflows, but typically you would radiologist read the CT images, generate some ground truth findings, describe them, and then based on that, providing impressions for recommendations. From a methods perspective, the easiest way is actually just directly throw the image into a vision language model and ask it to generate a radiology report. The approach is not new. There's actually a number of existing work on this topic, primarily in the computer science literature. This is actually where we started as well. We just took off-the-shelf vision language model. I think at the time we did Lava or Clip, and then feed the images in and ask it to produce the report for us. We failed, obviously, because the results are very easily hallucinated. And here's an example from the slide. The model naively reproducing the text from what is learned from past reports that was trained on, but not really looking at the images and not really producing the right information. And it seems to be very small differences, but clinically, they are very different. A new nodule is a very different thing than nodules that you are tracking from previous images. Why does this happen? And our thinking is a lot of these models are trained against traditional, what we call NLP, natural language processing matrix, to assess model performance, which is obviously not adequate. Why? As you can see the example, even through clinically, the model output is very different. The nodule size is different from 6 to 8 millimeters, and the texture is different, and the long-reads categorization is very different. Long-reads 2 means routine surveillance. Long-reads 4A means you have to do biopsy right away for diagnosis, right? And so it has very clear clinical differences. But from an NLP matrix perspective, it's really just comparing the semantic similarity between these two stream of texts. And as you can see, a lot of the words are actually overlapping, or the semantic differences are small. So the NLP matrix are actually not too bad. But clinically, this is a critical error. The model changed the location, the nodule type, and management recommendations. So what we did in this particular study is actually first design clinical meaningful evaluation matrix aligned with clinical guidelines. In lung cancer screening, it's lung reads and the NCCN guidelines, and which offers a stronger reflection of clinical accuracy than NLP matrices. And then the other thing that we did differently than the existing work is we actually designed our pipeline to mimic a radiologist workflow. So we actually talk to radiologists, we actually shadow radiologists on how they actually doing these imaging reading. So typically they will start with so it's a 3D and every slice is a 2D thing, but when you combine them, it's a 3D image. What they typically do is slice through a few hundreds of the slides and trying to first identify those that are large or suspicious nodules. And then they focus on the few ones that they identify. They started to do the measuring, what is the nodule size, and then look at the shape and the texture and document the basically the findings. So that's exactly what we did. We actually didn't start with vision language model. We actually went back to very traditional computer vision models on segmentation to identify key slices. So slices have suspicious nodule or slices with nodules that are big, right? And then we feed those key slices only, just like a radiologist, to the vision language model, and basically formulating a list of questions to the model with the slice. Is there a nodule? Where it is on the left or on the right? What is the size of the nodule? And what is the density and other kind of informations. And based on that, it basically formulating the description and basically the findings of the radiology. And then based on the factual findings, generating the report, the recommendation report, which in radiologist word is the impression according to the long reads guideline, which dictates the management recommendation as well. This is really just a slide looking at the prompt that we provided to the model, which is actually pretty simple, not that interesting. To demonstrate the effectiveness of our model, we obviously did a bunch of ablation study testing different baseline models and different baseline approaches. We tested two that we think that makes sense. One is a general domain vision language model called VILA. And then VILA has a variation called M3, which is trained on medical imaging and text data sets for tasks like this, because we think there are going to be a difference. And then we tested against three baseline. One is what we call VILA direct. Basically, you feed images in directly to the general domain VLM, And then the second variation is the M3, the medical domain VLM. And also, as I was saying, the CT image is actually 3D. So we actually find a 3D model because we saw maybe the nodule is 3D, the slices actually doesn't really can interpret the nodule size adequately. So we're just feeding 3D images. And then here's the result. It's a busy slides. I'm just going to summarize what it is. Don't have to pay attention to all the different numbers. The direct is the baseline. Lumen is our system. Basically, what this is saying is if you look at NLP matrices, we actually don't do well. We actually do much worse than all the other naive models. But if you look at clinical matrices, we do much better against the different guidelines. So I think the message is in healthcare setting, the pure performance is not really what we should be chasing, but really to teach the AI think like a clinician, that's probably more important. And this is just two examples of our error analysis. The errors are highlighted in red. As you can see, Lumen, which is our model, does much better than the other baseline models, which you can see a lot of hallucinations. But the other findings that as we look through these error cases in depth, when Lumen didn't generate the right result, and we also had radiologists and clinicians to double check the original images, and they actually found some of them may have been the original radiologist error. And which makes sense. If you look at the radiology literature, human accuracy is about 78 or 80%. So a human is actually not 100% accurate. So this is probably where the best value for AI is, having AI as assistant, kind of helping human to do a first pass, but also more accurate recommendations. Now, let me switch gear a little bit, kind of talk about real world evidence. In the last 2 or 3 years, our group has done a lot of these real world evidence study focusing on GLP-1 across different disease areas. A number of them are published in pretty high impact journal like JAMA Neurology or JAMA Oncology. So I'm gonna talk through some of those studies first. But before that, data and data quality is important. Study design also important. FDA actually in their guideline actually have a 3-part approach to evaluate applications of real evidence. And then the first piece is the real world data needs to be fit for purpose. The quality of the data needs to meet the clinical questions that it's trying to answer. Second, they do pay a lot of attention on whether the study design is appropriate or not. And then the last piece is more about the conduct of the study, which if you do RCT work with FDA, it's nothing different on how they evaluating randomized clinical trial evidence as well. But let me talk about data first. Real world data like EHR, as you can see, are really messy. Misclassification error is all over the place, right? So a good example is a patient with lung cancer diagnosis code doesn't really mean the patient had lung cancer. It can well just be part of the differential diagnosis process. This is insurance requirement. I have to put in a diagnosis code to fulfill the insurance needs, right? The patient doesn't really have that disease. So this is what we call misclassification and phenotyping error. And this is where computer phenotype algorithm can help us minimizing these sets of error. And then the other big piece is actually missingness, which you already heard me talk a lot about from an NLP perspective. A lot of these data are not collected from routine care, but even when they are collected, they are not readily available in structured data, but in clinical notes. This is where NLP are important. But if you also look at a lot of existing real-world data studies, they typically stop at the free text level, and it's actually not a whole lot. But there are a lot of other data modalities like imaging, like omics, like microbiome that's going to affect the patient care, right? So we really need that other data sets to be in the infrastructure so we can actually consider them. So as I can see, how to generate robust real-world evidence is largely a data problem from my perspective. The second problem beyond data quality is study design. I don't think I have to be laboring the point. Real-world data, observational in nature, which are inherent biased. In RCTs, a lot of these biases can be addressed with certain feature of the RCT design, right? So a lot of the selection confounding bias can be addressed with randomization. We really don't have that luxury in real-world evidence, in real-world data study. But at least we can standardize the protocol for the study, and there are a lot of statistical methods to mitigate these bias after you recognize them. You guys are better expert than I do on these statistical methods, so I'm not gonna talk about that. But a framework that we've been using quite a bit is the target trial emulation. You guys for sure have heard about it, and it's been quite popular. And if you look at FDA and the EMA guideline, in EMA guideline, it actually specifically named target trial emulation as the approach for rigor. And in FDA, even though it doesn't really talk about TTE as a named method or framework, but the process they are looking at is very much like the TTE framework. Itself is not a causal inference method. It's really just trying to provide you a thinking framework to provide transparency and rigor, right? So going through the 7 elements of target trial emulation, we really have to systematically think about what is the eligibility criteria of the population that we're studying for the question I'm trying to answer, how the treatment strategy is being observed in the data, what is the assignment procedures, what are the outcomes of interest. If you talk to epidemiologists in the past, a lot of time they really don't separate primary and secondary outcome as we do in RCTs, right? And the follow-up period is critical. What is the causal contrast of interest? Are you looking at safety so that I intend to treat is more appropriate, or are you looking at per protocol analysis, right? And then at the end, the analysis plan itself, what methods are you going to use to mitigate what specific biases? How do you do your diagnostics is also important. So you basically have a protocol like a clinical trial protocol to follow. And again, TT itself is not a causal inference method. It's really just an approach for us to kind of think through the problem more systematically. In the last 2 or 3 years, our group have done a lot of TTE. Many of them are focused on GLP-1. Not belaboring that. And let me talk about GLP-1 a little bit more. So GLP-1 and SGLT2 are newer class of glucose-lowering drugs. And when they started, they were started as second-line treatment. And we see quite a bit benefits in mitigating cardiovascular and renal complication originally associated with diabetes. But everyone is obviously well aware the the new GLP indication on obesity for weight management and weight loss. And in 2023, Wegovy actually was the most selling drugs. But more recently, Lilly, it's in the backyard of Indiana, became the biggest pharma company, exceeding $1 trillion because of Zepbound and the weight loss drugs that have. Also, more recently, real evidence on GLP-1, a lot of them actually produced by our group, has suggested additional benefits. For example, reduced risk of dementia and some of the psychiatric disorders like depression, and also lowering blood pressure and others. So this kind of leads us to think about GLP-1 more broadly. And one thread of this research is on cancer outcomes. Why do we study cancer is obvious, right? Obesity is actually one of the largest modifiable cancer risk factors we have. It's a consensus that we have now, but if you ask the field 15 years ago, probably not the same case. I actually had an early NCI proposal 10 or 9 years ago, looking at obesity as risk factor. The feedback I've gotten from the study section is, well, we don't think obesity is a risk factor, so you should not be studying it. But obviously the field evolved and obesity is kind of established. And as the CDC figure shows, being overweight or obese is linked to 13 different cancer types, and about 40% of all cancer diagnosed in the United States are obesity-related cancer. Since GLP-1 is the most effective weight loss therapy we ever had, the question of how it leads to whether it has any effect on obesity-related cancer is of interest. So before we did the real evidence study, we actually did a meta-analysis of existing trials first. As you can see, this is actually not cancer focused. We pulled 26 pivotal trials covering about 200,000 participants and study across 6 different disease domains. And when you focus on cancer, we don't see any signal from the meta-analysis of trials. There's some borderline signal on thyroid, which actually show its increased cancer risks. Okay, but broadly, it's all inclusive, not conclusive. This gets into some of my talking points. Existing RCTs are insufficient to evaluate long-term impact of GLP-1 on cancer. This is why we say real evidence is important, because all of these original pivotal trials, none really assess cancer as a pre-specified endpoint. So it's just a byproduct of the reporting. And most of those trials have very short follow-up period, and typically RCTs no more than 3 years, right? So cancer is not a short-term disease. The development of cancer takes a long time. And also, all these pivotal trials of GLP-1 actually excluded patients with prior history of cancer. So it's really looking at a safe population, right? Low-risk population. This is where real-world data comes into play and why it's important. I'm not going to go through the study design in too much detail. This is the target trauma emulation study we did with the One Florida EHR covering 14 different cancers. So the 13 obesity-related plus lung cancer, just because I have an interest in lung cancer, from 2014 to 2024. The adults is the population is adults eligible for anti-obesity medications, so which are BMI over 30 or over 27 that with comorbidities and no prior cancer history. The exposure is GLP-1 initiation versus non-use. We specifically picked the non-use use case because of the data limitations. And we also did the time-dependent 1-to-1 propensity score matching rather than a traditional propensity score because of the exposure issues. After matching, we find about 40,000 case and controls. The results are interesting. It shows protective effect overall, but particularly in endometrial, some of the reproductive cancers, endometrial, ovarian, and also meningioma, but does increase kidney cancer to some degree. I mean, the the confidence interval cross 1, but it's 0.99, right? We also have a companion study that we actually look at Medicare data in type 2 diabetes cohort, and the kidney cancer risk is also significant. But there are two caveats. One, this is the general obesity cohort in EHR. The Medicare data is type 2 diabetes only, because at the time, obesity is not an indication that Medicare can approve, right? So it's primarily still type 2 diabetes drug. And the second, we actually compared it with our active comparator in the Medicare study. So comparing GLP-1 with SGLT2, and it does increase kidney cancer risk in that context. So the context is really important. And these are a set of other studies that we've done on TTE and GLP-1. This one's actually particularly looking at GLP-1, SGLT2, again in type 2 diabetes for Alzheimer's disease and Alzheimer's disease-related dementia. I'm not gonna be laboring the study design too much, but we actually did a three-way comparison. So comparing GLP-1 to other glucose-lowering drugs like DPP, and then comparing to SGLT2, which is also a newer class glucose-lowering drug. And then we did a head-to-head comparison of SGLT2 versus DPP as well. The result is also interesting if you're looking at GLP-1 versus other glucose-lowering, the old generation. It shows protective effect, and you see the same effect in SGLT2, and you actually probably see a little bit more in SGLT2. And then if you look at GLP-1 versus SGLT2 head-to-head, there's no differences, right? So what does it mean? When we look at GLP-1 versus SGLT2 in cancer and other diseases, there's significant differences. But in the context of neurodegenerative disease, there's no differences, right? Obviously, I'm not giving clinical guidance, but if we have sufficient RCT data in the future saying GLP-1 and SGLT2 can be a prevention drug for dementia, SGLT2 may be a better choice because if you're considering cost and other aspects, it has the same level of protection, but it's much cheaper, right? So that's one caveat when we have to think about these real-world evidence results. And the other piece is actually on heterogeneity in treatment effect, the benefit's not universal. And we did some causal AI, and it's actually very simple, doubly robust causal forest learning. And the most benefits is actually in cardiovascular disease. People with cardiovascular disease, with cerebral vascular disease, the protective effect is much higher, which does make sense clinically to some degree. But if you're looking at some of the other comorbidities, like patient with chronic kidney disease, the benefits is not that much. Okay, so it also helps us to think about these heterogeneous treatment effect as well. Obviously, mediation is a consideration at the time, whether the outcome is a direct effect from GLP-1 to Alzheimer, or it's mediated by the A1C control and BMI. So we actually did that mediation analysis as well. I'm not going to go through details, but the interesting result is it's not entirely because of diabetes control and BMI reduction. So yeah, does have some effect on the outcome directly to some degree. So if you're aware of the GLP-1 literature, there's actually repurposing of GLP-1. There's actually ongoing. Well, the trial actually concluded the result is no effect, but it does help us to think about whether we should consider repurposing GLP-1 for some of the other diseases as well, right? So indication is still expanding, but the real world evidence can help us to figure out the right directions. So I think a few last talking points. Working with real world data on this topic obviously come with its own set of challenges. Alzheimer's disease (ADRD) is often misclassified, as I was talking about earlier. They are even more misclassified with ICD codes. So applying a validated computational phenotype algorithm is important. We actually did that. We developed and validated computational phenotype with EHR. And if you look at just pure ICD code positioning, it's for AD and ADRD, it's only about 0.76 across the literature. But with validated computer phenotype, the position can get up to 0.85 or 0.86. But it's also a trade-off because you're going to lose sample size, right? So again, consideration is important. And the second point I want to make is when you're looking at real-world data, the endpoints are actually very different because of the data limitations, right? Take Alzheimer's disease as an example. The typical clinical trial endpoints are things like clinical dementia rating or MoCA scores. Those are not typically captured in routine care, right? Some of them do, but not all of them are. So for those that are, we developed NLP tools to kind of extract them, and we can find, but the prevalence is pretty low. But if it's not available, then how do we study endpoints? The other way to make endpoints comparable, maybe thinking about surrogates. So taking cancer as another example, the typical trial endpoints will be progression-free survival, but progression will need to be defined by imaging criteria, which is not typically available in structured data in EHR. One way is to do NLP, obviously, but the other way is looking at surrogates. So this is another study we did. We're actually looking at using time to next treatment that you can readily grab from structured EHR data as a proxy of the progression-free survival. So we actually did a study and validated the measures. I think this is my conclusion slides. I think I'm just going to end with this point. I think how to generate robust real-world evidence is largely a data problem. I hope you guys agree with me to some degree. Thanks.